Okay, I'm going to talk about the update in device technology regarding cardiac resynchronization therapy. Okay, تعال حرك بقى mouse. Okay, space. Okay. Of course, you know the electrical desynchrony and its association with the mechanical desynchrony, and its prevalence 30% in heart failure patient. The electrical desynchrony is mainly left bundle branch block, and this will make the desynchronous contraction between the septum and the lateral wall as confirmed by echocardiography and special tissue Doppler imaging. This is one of the cases where we implant CRTP, okay. CRTD. This is the defibrillator lead, and then injecting the CS catheter. Yes, and this is the decapolar lead, and as you compare this with the case of the morning, the delivery of the CRT coronary sinus lead is over the wire. I start with the PCA wire first, and then I deliver the lead. I don't go with the lead in the beginning, but I inject first, and then we deliver the quadripolar lead afterwards on the PCA wire, so that I can see the vein and make stability. I don't go with the stylet. This is different techniques of operators, but I start with the PCA, go inside the vein, make sure that there is no valves, and so forth. So, and because this quadripolar lead from the technology, it helps us to choose which poles to pace. And this is one of the cases with the typical left bundle branch block before CRT and after CRT, where the complex is beautifully narrow. Actually, we don't see this all the time. We hope to see this, we wish to see this, but this depends about the site of the lead, I think the dilatation of the ventricle, the myocardial captured by the poles. It depends on many things to get this beautiful narrow complex after CRT pacing.
And also the really interval adjustment.
Yes, yes.
Very important.
Yeah. This is the echocardiography on the short axis view at the level of papillary muscle. This is before and after, and we can see here the very good contraction and the improvement. Yeah, synchronization. Can we skip this? We'll go to the benefits of CRT compared to optimal pharmacological therapy, improving ejection fraction, NIHA class, 6-minute walk test, and I stress on the fellows, you have to have the 6-minute walk test as an objective, not subjective, because in different cultures, people complain differently. I don't know what they do in Europe, but in Egypt, the patient like to complain more and more and more, so that she gets the utmost attention of the doctor. So, if you get this kind of patient, which is about 80% of the patients I see in my clinic, you have to have an objective test. With that objective test, which I do, I make one of my assistant to have his stopwatch, and there is a distance in the around, yeah. And see, you are good, you did great, you improved. So this is the objective test. So I stress.
I will tell you a very important tip I do with my patients. I tell them that if you are still complaining, it's okay, you need more and more diuretics, and I will give you more diuretics, and this will compromise your kidney function. Full stop. I can't leave you like this. Please, if you are not really complaining, stop saying this to me. And they
objective test is the 6-minute walk test, or make them go upstairs, downstairs, because they think the more I complain, the more you give me attention. As we know that CRT reduces all-cause mortality, cardiac and heart failure hospitalization, and compared to ICD, it decreases hospitalization and also decreases the risk of death. Improving the response to cardiac resynchronization therapy, by the technology. This started by improving the lead technology. I implanted the unipolar lead in the first case who received CRT P in Egypt. Was in this hospital. It was Mazen's first case of his MD thesis, and that was a lady who had postpartum cardiomyopathy, and the device was Ella. It was Ella, and the lead was not the lead. You adjust the end of the lead. The lead comes so that through the sheath, you can go through the sheath, and then you pull out the sheath, and then you have the extension of the lead with the bipole ends, and it was a unipolar lead. Then they went to bipolar lead, and then to quadrupolar lead, and I prefer, if I have the facility, I prefer the quadrupolar leads. First, you can go inside the vein down, and you choose the poles you like. Second, if you have phrenic nerve, you can escape this phrenic nerve. For my fellows who were not there when Mazen was doing his MD thesis, this is the unipolar coronary sinus lead, and this is the bipolar, and this is the quadrupolar lead. The development also involved the shape of the leads with the S shape and these two angled leads in order to suit different shape of veins. And before I choose the lead, I inject the CS. I look at the morphology of the lead. I look at the size of the lead. I compare the size of the lead with the size of the injecting catheter, which is the sheath I'm using, in order to imagine which lead is the best in stability, in entering the branch, because not all cases are easy. That was an easy case with some other difficulties. Introduction of the CS lead in this morning was not difficult, but the other stuff around it was sort of difficulty. Of course, companies compete with the different shapes of leads, and also the spacing between the poles is also an issue of invention. Yes, this is, as we saw, the before and after. And now the vector of the lead, which pose is the best. We used to do this by echocardiography in the echo lab with our echo team. They were very patient with us. We changed the configuration, VV interval, AV interval, the sense and the pace. It took us a long time to do this. Until then, they invented the better solution I will show you. As we were discussing this morning, remember that Mazen pulled the bipolar lead away from the apex, and Rania was asking him, "Are you sure the lead will be stable?" And he answered her, "Yes, I'm sure, because my sheath is inside the vein. After the neck of the vein, I'm not inside the CS, because my guiding catheter is deeply inside the vein, so my lead is stable." And he had to pull the bipolar lead in order to be midway between the base and the apex, because there is a study which showed that very bad outcome, which is the med CRT from the apical position, and they recommended the mid-basal position. Remember that when we implant a dual chamber pacemaker, we ask for less RV pacing, and Dr. Blashka showed us that if you have more than 40% RV pacing, this is deleterious to the left ventricular function. So, on the contrary, with the CRT, we need 100% by V pacing. The concept is different. The lead vector is the invention, and I like it. This is the CRT quick opt solution from St. Jude, and they showed that they evaluate the effect of quick opt. Quick opt is automatic. The machine does it, and the Chinese took the advantage of having no regulations in their country to make this study, trying this quick opt solution in 400 heart failure patients, comparing it to the regular echo, and they found very good results. That quick opt is a rapid, simple method to carry out the optimization of the AV and the BV delay, and especially compared to the echo, which is the gold standard. And they said this is good for our busy cardiology department in order to reduce their precious clinical time. Okay, then comes the why not to pace more than one site in the left ventricle, and here comes the multi-point pacing. If I have 4 poles, why not to pace from these poles and these poles in order to capture more myocardium, and then here comes this idea. The multi-point pacing using this, and we have it, we are lucky to have this technology here in our machines, but when I tried it in my clinic, immediately the longevity of the battery was half, because you are draining the battery to 2 sides. If the lifespan of the patient is not that long, I think I would use it. But if I see that patient has improved with one side, not multi-side pacing, and the battery will be depleted soon, I did not use. So, because immediately you will see that the longevity of the battery will be affected. This is the multi-point pacing. Yes, it is in the technology we have. It will capture more tissues, and it will give us better resynchronization. Here I like this explanation because I didn't know before. In this, this explanation of why is this concave pattern of electrical activity is better than the convex or the flat. From the electrical current, they showed that this concave here, this is the lead, LV1, LV2, the propagation of the current is fastest. The fastest is the concave part. This is what was written in this presentation. Also, the fastest propagation comes from one line of electrodes side by side, and this is what is shown in this diagram. So the fastest conduction is the better because you allow more myocardium to contract together. The SyncAV CRT technology is the next step. Why should I pace the right ventricle? The right ventricle is the bad guy. When I pace the right ventricle, I deteriorate left ventricular function. Why not use it as a signal to give order to the left ventricle to pace before it, so I save right ventricular pacing? So come this idea of SyncAV. This SyncAV technology adjusts the AV delay based on patient intrinsic conduction, and this was published in Journal of American Heart Association, programming the cardiac resynchronization for electrical synchrony, reaching beyond the left bundle branch block and left ventricular activation, and they showed post-implant electrical optimization is already well-selected patient. Optimizing LV position is facilitated, tailored by BASAL pacing, and we'll see this. I like this. I like it. Because this is the signal. The lead will sense the RV and will fire the LV and will make them contract together. In this dynamic timing of the quadrupolar CRT device, in this multi-point pacing, individualize the dynamic adjustment of the AV delay. This is automatic, done by the machine, based on the intrinsic patient rhythm. This will help also for patients who have short AV delay or fast AV conduction. Sometimes you make it shorter and shorter, and the patient exercises, then the CRT is not effective. And if you do halter, you will see it. The pacing is not effective because of the fast conduction. Now, if you use this technology and you synchronize with the native conduction of the patient, now you solve many problems and you avoid RV pacing. This is, at the end, will lead to fusion with the intrinsic rhythm for improvement of electrical synchrony and narrow QRS. I like it. This is different ECGs. This is the multi-point pacing with the syncing LAV, and this is a multi-site with no syncing, and they compared the QRS complexes. Medtronic was not behind St. Jude Abbott in adaptive CRT, and they also have the technology. They have it in, I saw it in my clinic. One day I was implanting a patient, and after implantation it was on, And I saw marvelous ECG. I did not fix anything, but as soon as the patient received the CRT firing, CRT optimization worked on, and I saw very good. But this same patient had atrial fibrillation few days after, and the CRT, adaptive CRT, is gone because it does not work in AF. So I have to convert her to sinus rhythm and make it work again. Okay, this adaptive LV pacing in Medtronic uses the same principle of syncing or sensing the RV and firing the LV. What do they call adaptive by V? Because you will see it on the programmer. I didn't understand until I made this lecture. The company does not explain to me. Okay, so this by V means by V pacing, not sensing the RV. And they published this using the adaptive CRT is associated with a significant reduction in the probability of 30-day readmission after both heart failure or cause mortality. And this was published in JACC journal for heart failure. And they said that this technology decreases the incidence also of AFib in such patients on 30 days. And thank you.